أهلا بيكم. Today we will talk about the pleura and lungs. So let's begin. The pleura is a single layer of flat cells, mesothelial cells. Think of it as a closed bag, and you drop the lung in it, not inside the bag itself, no, but from the outside to the invaginate the bag, I mean, to cover all of the lungs. So you will end up with two layers surrounding the lung, the parietal layer and the visceral layer. The parietal layer that lines the thoracic cavity, and the visceral layer that's directly applied to the lung and goes with its fissures and it's adherent to it. The cavity between the two layers is the pleural cavity, and it's a potential space filled with a thin film of fluid to allow easy gliding of the lung on the during the respiratory movements, inhalation and expiration. Okay, the parietal pleura, it takes different names according to its site. There is a costal pleura. The costal pleura is the pleura that's related to the rib cage. The diaphragmatic pleura that covers the diaphragm and the base of the lung. The mediastinal pleura that covers the medial sides of the lungs and the part that contains the hilum, and the cervical pleura, the part that projects into the neck, but actually not above the level of rib 1 posteriorly, and we explained this in the root of neck before, because there is the oblique slope of the first rib, the thoracic inlet. See, posteriorly it reaches to the level of the neck of the ribs, but anteriorly it's above the costal cartilages, so it's considered part of the root of the neck. Okay, now to keep this pleura in place, the cervical pleura, there is a membrane that covers it called the suprapleural membrane. It's attached to the inner border of the rib 1 and by a ligament to the transverse process of C7 called the apical ligament. And remember, recall that sometimes you might find some muscle fibers in this membrane or this ligament actually, and they call it scalene minimus. Okay, you remember this from the root of the neck. Now, the costal pleura, innervated by the intercostal nerves, means that the pain is referred to the thoracic wall. They call the pain from the pleura pleurisy. When we get cold, when we get the flus, you feel some stitching pain in the chest wall. This is because of the inflammation of the costal pleura, while the diaphragmatic and mediastinal pleura supplied by the phrenic nerve C3, 4, 5, so you expect the pain to be referred to areas supplied by such dermatomes like the side of the neck and the supraclavicular region of the shoulder. Okay, it's reflected in parts. Superiorly, the pleural cavity, we said it reaches above the costal cartilage. Anteriorly, the pleurae descend together and they meet behind the body of the sternum in the midline, but at the level of the fourth costal cartilage, the left side pleura deviates to the left and then back again to the sixth costal cartilage. This is because of the heart is present there. So actually this is called the cardiac notch of the lung. And as you can see, the recess formed is biggest here. It's called the costo-mediastinal recess. We'll talk about it now. Inferiorly, the pleura deviates laterally. the inferior margin of the pleura. It cuts the mid-clavicular line by rib 8, the mid-axillary line by rib 10, and posterior to the 12th thoracic vertebrae. So remember 8, 10, 12. Because the lung is 6, 8, 10. That's why there's a recess between the lung and the pleura. So now we're talking about the pleura. It cuts the mid-clavicular line in the 8th, mid-axillary line in the 10th, and posterior to the level of T12 thoracic vertebra. The visceral pleura, it's continuation. As we said, it's a closed bag. So continuation, but covers the lung and goes with the fissures and reflected around the hilum, as we will see soon. Okay, the visceral pleura is innervated by the visceral afferent fibers, but pain is not elicited in injury of these tissues, only for the pain felt from the ones supplied by somatic supply. Okay, the recesses. Recesses means an area where the two parietal pleura oppose each other. Like the costomediastinal recess, it's very thin here from the cervical pleura downward with the anterior border of the pleurae, but it's widest, as we said, between ribs 4 and 6, because the lung deviates to the left side because of the cardiac notch. And this is the biggest part of the costomediastinal recess. There is another recess which is clinically important, the costodiaphragmatic recess. This recess below, the one you look at in X-rays. You look at the costodiaphragmatic angle here and here, because now you are in the costodiaphragmatic recess. Why it's clinically important? Because this is dependent area, and any pleural effusion or any blood in the cavity will accumulate in the angles and will obscure the angle from the X-ray. It will turn white. Okay, so they should be clear. You should always look for the costodiaphragmatic angles. Also, in this X-ray picture, I want you to draw your attention to these what so-called hilar shadows. Hilar shadows. See, it's because of the splitting of the bronchi and the lymph nodes. The hilar lymph nodes make this shadow. Okay, so in X-rays for the chest, actually you look for the angle, you look for the hilar shadow, and you look for the cardiac shadow that we will discuss later when we study the heart. Okay, we talked about pleural effusion. Pneumothorax, instead of fluid, there's air in the pleural cavity, and the patient gets this when with open injuries, actually, like the flail chest injury we talked about with the thoracic cage. Now the lungs. The lungs are the respiratory organs. Actually, the lung is the end product of generations of splitting of the bronchi. They continue dividing until they reach the alveolar levels, and the sum of the alveoli are the lung, like a cauliflower flower plant. Did you observe the cauliflower plant from the inside? It's the same like the lung. Continuous splitting of the bronchial tree that will end up in alveoli, and the sum of the alveoli are is the lung, actually. Each lung has an apex, has a base which is related to the diaphragm, has a medial surface, has the hilum that has a lateral surface or costal surface. Excuse me. Costal surface related to the ribs, anterior sharp border and inferior sharp border, and a posterior, actually it's not a border, it's a blunt surface, curved surface, but you can call it a blunt border. Okay, so anterior sharp border has inferior sharp border and posterior surface. This is the way you recognize right from left. Where is anterior, where is posterior, where is superior, where is inferior, where is lateral, lateral that's related to the ribs, and medial that has the hilum in it. This is how you differentiate right from left in practical exams. The root and hilum of the lung. The root is the structures entering or coming out of the lung. So it's structure, a structure, the things that go inside and come from the lung, like the bronchi, like the pulmonary artery, the pulmonary veins, together. This bunch of structures is called the root. But the hilum, this is an area that belongs to the lung, not to the structures entering. The hilum is where the structures enter. This is the hilum. Or you can define the hilum as the part where around it the pleura gets reflected. See? Gets reflected to cover the root. And around the root, the pleura gives a slack below the root of the lung called the pulmonary ligament. This is the pulmonary ligament that allows for the descent and ascent of the lung during respiratory movements. Also recall the fact that in front of the root passes the phrenic nerve, behind the root passes the vagus nerve. Immediately in front, immediately behind are the phrenic nerve and the vagus nerve respectively. Okay, each root contains the pulmonary artery, the two pulmonary veins, main bronchus, bronchial vessels, the nerves and lymphatics. Arrangement: roughly the veins are at front, the bronchi at the back, and the artery is in the middle and superior, the pulmonary artery. As you can see here, this is the pulmonary artery, and this is a branch of it. This is a main bronchus, and this is a branch called the epiarterial bronchus, because this is the right side. The bronchus divides early before entering the lung. And anterior, you will find cut sections of the pulmonary veins, the right and left superior and inferior pulmonary veins. To distinguish right from left lungs, actually, yes, some people say look at the fissures, because the right lung is different than the left lung. In the fact that the right lung has an oblique fissure that extends from T4 level behind to the rib 6 in front, and the transverse fissure or horizontal fissure that starts from the fourth space and goes laterally to intercept the oblique fissure, whatever it may be, the site of interception. So you will end up with three lobes. But trust me, doctors, this is not the main difference, because I dissected many lungs, right lungs with only one fissure. So actually do not count on the fissures. No, but count on the anatomical position. Where is anterior, where is posterior, superior, inferior, lateral, and medial. And you have in the right lung superior, middle, and inferior lobes. Now, when you hold the lung in your hands, you will find that these parts are almost separated from each other, freely mobile on each other, because the visceral pleura invaginates through the fissures till the hilum, actually. Okay? Now, we have what's so-called the pulmonary impressions, means the impressions of the nearby direct contact structures on the lung, and this you get after, after embalming the body. It's not in real life. It's soft tissue and doesn't have any impressions on it during real life. Okay, so what do we have here? This is the right side. This is the right lung. So behind the root, there is the azygous vein impression, This is the azygos vein, and this is the arch of the azygos. Now the azygos will end up in the superior vena cava, so this is the impression for superior vena cava. Superior vena cava will end up in the right atrium, so this is the cardiac impression, which is the right atrial impression on the right lung. So again, right atrium, superior vena cava, the azygos vein, the arch of the azygos and the azygos itself behind the root, and at the top the subclavian artery, all vessels actually making an impression on the apex of the lung. Of course, you observe the diaphragm impression at the base, the cupulae, and at the back you will find the impression of the vertebrae, thoracic vertebrae, behind, of course, the azygos vein. Okay, this is the right lung. The left lung, this is anterior, posterior, superior, inferior, and this is the medial surface we are looking at. There is a cardiac notch because of the heart is displaced to the left side. There's only one fissure. I saw lungs with two fissures, by the way, left lungs. The oblique fissure, the same surface markings from T4 at the back and to rib 6 at the front. Now, you will get confused identifying the lingula. The lingula is in front of the fissure, not at the back. So this part is the lingula. Actually, you will not commonly find it as one process like that. No, multiple processes. So don't get confused. The lowest one, you will even find processes here. But the one that is directly in front of the oblique fissure is the lingular process. Represents the middle lobe in the right lung. So even has the same distribution, the bronchial distribution from the bronchial divisions. Okay, what do we have here on the medial side of or medial surface of the lung? We have the impression of the descending thoracic aorta with the esophagus in front of it. Esophagus, descending thoracic aorta, a continuation of the arch of the aorta. This is the arch, and this is the ascending thoracic aorta impression. And the cardiac impression here, what do you think it is? Exactly, it's of the left ventricle, giving rise to the ascending thoracic aorta and the arch of the aorta. The subclavian vessels make their marks on the top of the lung, the apex of the lung. So it's totally different, of course, than the right side, and you should know this, learn this by heart. Okay. The bronchial tree, the trachea, remember, starts at level of C6 as a membrane called the cricotracheal membrane, and then starts the incomplete rings, cartilaginous rings, and alternating rings and membrane to form the trachea, and at the back it's completed by the smooth muscle trachealis, responsible for constriction and dilation of the trachea. Now below and at the plane, famous plane that passes through the angle of Lewis, level between T4 and 5, the trachea splits into right and left main bronchi, and the last cartilage of the lower down from the trachea is called the carina of the trachea, and it's a cartilage that's continuous from the front to the back to guard the splitting of the trachea into two main bronchi. Now observe that the right main bronchus is wider than the left main bronchus. See, this is narrower than this one. And the main bronchus, the right main bronchus, is more vertical than the left. This means that any foreign object that enters the trachea will most probably lodge into the right side. So the incidence of lung abscess in the right side is more common than in the left side because of this reason, because of the shape and direction of the main bronchi. Now after the main bronchus develops, it splits into um, um, secondary bronchi or lobar bronchi. Then each lobar bronchus will split into segmental bronchi. Segmental, we will talk about that after this slide. But generations of splitting till you reach the final stage, which is the alveolus that makes the body actually of the lung. All these are thousands of alveoli because of the generations of splittings of the bronchi. It's easy. Okay, bronchopulmonary segments. A segment of the lung means that it's part of the lung that's supplied by a tertiary bronchus. They found out that this tertiary bronchus, with the part it supplies, the bronchus represents the apex, and the part it supplies on the surface actually make a pyramid. It's individual in its blood supply and its bronchial divisions, so you can remove actually the segment, without affecting the nearby segments. Okay, and this is what the map they follow in pneumonectomies when the surgeon wants to perform partial pneumonectomy, means to excise part of the lung because of a cancer, for example. This is called the bronchopulmonary segments. Actually, the segments are in the apical part, anterior, superior, apical, anterior, and posterior. In the middle lobe of the right lung, it's lateral and medial, but in the lingula, it's superior and inferior. And below, it's the same: apical, anterior basal, lateral basal, posterior basal. I was asked before, which is the lowest part of the lung? It's the posterior basal segment. Posterior basal segment is the lowest part of the lung. Okay, some books you will find it, by the way, lateral basal, but it's very obvious here. This is the posterior basal segment of the lung. Okay, about the supply. Actually, we will talk about the functional supply. Look, doctors, for the liver, for example, there is dual blood supply through the portal vein and blood supply through the hepatic artery. The hepatic artery is for the nutrition of the organ, but in the portal vein, it's for the function of the organ. The same thing here. The pulmonary arteries that arise by a pulmonary trunk from the infundibulum region of the right ventricle, which is a smooth area in the walls of the right ventricle, guarded by a valve, the pulmonary valve. It splits in a T-shaped manner into right and left pulmonary arteries. The right is longer than the left and lies behind the inferior vena cava and the ascending thoracic aorta. The left one is in front of the aorta. So don't get confused. The right is behind the aorta, but which part? The ascending thoracic aorta. And the left side is in front of the descending thoracic aorta, and they enter the hilum of the lung. Now, observe that the pulmonary artery is always colored blue, as if it was a vein. Actually, it carries deoxygenated blood. Actually, there is a difference, doctors, between oxygenation and oxidation. Oxidation is a chemical reaction. Oxygenation means the blood carrying oxygen. So it's deoxygenated blood. But why did they call it a pulmonary artery, in spite of the fact that it carries deoxygenated blood like veins? You will be asked this question. It's because of the composition of, or the structure of the wall. The structure of the wall of the vessel is like an artery. The structure of the wall of the pulmonary veins is like a vein. Why do you need this, actually? You need a high pressure system to perfuse the lungs for its function, to function correctly. But you need a low pressure system to extract the oxygenated blood hurry up. You want to extract it as fast as possible to be delivered to the body. That's why we have a low pressure system, the pulmonary veins, which carry oxygenated blood and colored in red, and the pulmonary artery, which is colored in blue, and it's still an artery because of the structure of its walls. We have superior and inferior right pulmonary and left pulmonary veins. Okay. The last to say about the lungs are the bronchial arteries and veins. Bronchial arteries are the nutritive arteries for the lung. Look, doctors, the pattern of splitting of the bronchi is the same as the pulmonary artery, is the same as the bronchial artery. But the tributaries of the pulmonary veins do not follow this pattern. See here, this is the pulmonary trunk, this is the pulmonary artery dividing. See the blue divisions? They go with the tracheal divisions. See, these are the tracheal divisions. They follow the tracheal divisions. And posterior to these, at the posterior surface of these bronchial divisions, we'll find the bronchial artery actually sticking to its back. But note that this is the pulmonary vein, colored in red. See, the tributaries do not follow the branching pattern of the bronchi. You will be asked about this. Which of the following has the same pattern of divisions? So the bronchial artery, the same like the pulmonary artery, the same like the bronchial tree, and the different part is the tributaries of the pulmonary vein. Now, they ask you in another way, if you're performing a pneumonectomy, partial pneumonectomy, removing part of the lung, and you get a bleeder, actually when you're cutting around the segments, most probably the blood from this bleeder is high in oxygen content or low in oxygen. Well, think about it. If you're doing a pneumonectomy, actually you're removing segments of the lung, so you shouldn't get that much of a bleeding, because we learned that the segment is an individual part of the lung that can be separated without affecting the nearby structures. So most probably this blood will be high in oxygen content because it belongs to the tributaries of the pulmonary veins, colored in red in this specimen. The innervation, the lung and visceral pleura supplied by branches from the anterior and posterior pulmonary plexuses. These are plexuses in front and behind the tracheal bifurcation, and it's formed by branches from both vagi and the sympathetics, postganglionic sympathetics. The vagal stimulation constricts the bronchioles, while the sympathetic dilates the bronchioles. Bronchioles are the terminal part of the last part that has cartilage in the bronchial tree. Then you get the respiratory bronchioles and alveolar ducts, then alveolar sacs and alveoli. This is the bronchial tree. Lymph drainage to the tracheobronchial lymph nodes, all of the lung to the both lungs to the tracheobronchial lymph nodes. Then they form what's so-called the bronchiomediastinal trunk, that the bronchiomediastinal trunks that will eventually join the thoracic ducts on the left or the right. Now we talked about pneumonectomy. Bronchoscopy is the procedure by which you want to visualize the bronchial tree. You can introduce a dye there and make an X-ray picture to see. It's called the bronchogram, where you can visualize the bronchial tree. Any displacement in the bronchial tree will be a result of mass like a tumor, or for example. And I drew your attention to the hilar shadows that represents the beginning of the bronchial tree and the hilar lymph nodes, the bronchopulmonary lymph nodes at the hilum of the lung. Okay, this is the last to say about the lung and pleurae. I hope you got the maximum benefit from this lecture, and thank you very much for watching.